Good morning, everybody. I'm probably preaching to the pulpit right now. I think, there's like more of you. There was originally only four. There's something like 8 or 9 students. For the students that aren't on this call currently and watching this video, I'll probably shooting you an email because there's a new policy now for this term. On the ground classes, you must attend the Zoom session for attendance now. Before, like, if you did some work, it would be kind of like online. Like if you did some work before like 12 noon Saturday. So if you're unable to consistently make this Zoom session, and our Zoom sessions for this, Pharmacology, MED240, and it's 7DAX, so it's 9 a.m. on Thursdays. We have laboratory weeks 8, 9, and 10. And those dates are March 4, March 11, and March 18, and there will be an announcements, okay? And for those of you who had laboratory with me before, it's the same format of laboratory. We scrub in, you bring minimal, you don't bring any personal items as much as possible. And we scrub in and try to wear some scrubs or lab coat, and if you don't have, shoot me an email, and we'll have a lab coat ready for you. But all of that will be in the future, and also I put it way far back in the term, all the way in March, all the way in week 8. Remember, this is a 10-week term, so that we don't have to deal with that. This is, if you look at this is a lecture course, but those on the ground courses are scheduled. So we'll be meeting on the ground. But again, back to what I always say, if you do not feel safe, if you do not feel that you should be going out and going to school, please give me a call. Okay, I can find a alternative assignment. And also for those particular lecture days, week 8, week 9, I'll have a lecture. Also, even though this is a lecture class, we talk about pharmacology and parentologic medication administration. That's usually in other classes, but for you guys, you're coming in anyway, might as well play around with needles. So we'll probably be doing that either week 8 or week 9, and week 10 will be reserved for our final. So what does this course look like? I have to state that this is not my Moodle shell, so I'll be playing with it. And the person who created this Moodle shell is Dr. Cisco. She's a pharmacologist. She has a doctorate in pharmacology. So it's crazy chock full of a lot of good things and a lot of extra things. And you could see here, we have evolution of medicinal drugs and concepts of pharmacology for our first topic. But she added all this extra stuff, and we're going to try to go through some of these as well. Okay, so let's go through the syllabus so we know what's in store for us for the next 10 weeks. Do I have everyone? 1, 2, 3, 4, 5. Okay, that's currently, and that's being recorded. Okay, because I have to post attendance today. So those of you who probably had me before, the late policy honor code, don't worry about introducing yourself. I know all you guys already. I've had most of you before. And if I haven't, we can talk offline. Get through this introduction stuff. Because we want to jump right in, because this is a pretty decent, hefty course. And one way you could start this course is you can start looking up online the 200 most common drugs, and for your not only for this class, but for you going out into the world. And my daughter and my wife were supposed to do, but COVID hit. They were gonna come into the campus and talk about what courses translate very well into the real world, and both of them agree. Your pharmacology courses, you need to know several things about the 200 most common drugs in this world. 1, its proprietary name. 2, its generic name, if generic is available. It goes 3, what is its what is it? Is it a drug of choice? Is it a supplementary drug? Like, what is that drug's function? And if you in their lecture, hopefully we can, you know, get back to campus and or maybe do an online thing with either my daughter or my wife. They both work in the medical field. They say that knowing your pharmacology is key. It'll save you a lot of stress and a lot of trouble. And my wife works in the administrative field of medicine, and my daughter is a nurse. She's clinical, and of course clinical, it makes sense. Pharmacology, logi, study of drugs. And we know from anatomy and physiology that your body's in balance, and that's all that we do when we use drugs. We try to keep your body, we try to move your body back into balance. So the prerequisites make sense. You should have taken anatomy and physiology prior. You know my contact information. It's already on the announcements. And I have to reiterate, please call me during normal business hours, like 9 to 5. I had a student wake me up at 6 o'clock in the morning. I thought it was a family member. So of course but I wasn't thinking. I have a business phone, I have a personal phone, and I was looking at it. I thought it was my personal phone. So of course I pick up, and it was a student asking me about a change of grade at 6 o'clock in the morning. If it's something like that, just text. But if it's something like, Dr. Garais, I'm in the hospital at 6 o'clock in the morning, yeah, sure, call. But man, chain of grade at 6 o'clock in the morning, come on. So that's like another little public service announcement. And those of you who had me before, you know, I will answer within 12 to 24, even on a weekend. So that's what we're learning. We're learning drugs, okay? And the classification, right? What are the most common drugs? Federal laws regarding how things go down, which, by the way, these federal laws, I could teach you some of them, but as you can see right now, because of COVID, the FDA is pretty much throwing out most of their laws and just passing whatever they want to pass at this time. You don't believe me? Look it up. Drug takes forever to get approved. Now we're approving drugs left and right. And some of these new vaccines that claimed in the beginning, the end of last year, that they were 92 efficacious, we're now seeing numbers like 51, 48%. And efficacy, we'll learn in this this course, efficacy is how well does the drug do what it's supposed to do. So for example, a vaccine is supposed to prevent you from getting sick. That's why I don't like that number that Pfizer was throwing out in late November, early December, 92%. That means that 92% efficacy means that for out of 100 patients, 92 of them should be protected. Now we're seeing numbers like 48, 47, and that's also the reason why the laws were created in the first place. You have to have long-term trials, and you have to have lots of patients. They were saying, oh, 200,000, 400,000. No, you have to have patients in the millions, so that you know if there's any side effects, any bad things. And the reports are coming out now. They're sporadic. It's not bad, but there are a lot of problems. And you know, there's a reason. If you've had me before, I always say this: in medicine, we put rules in place for protection, protection of the facility, protection of the patient, for overall safety. When we start skirting those laws, that becomes a problem, and we're now seeing the real life effects of those problems. Again, the indications of use. Now, if I mention the word DOC, or drug of choice, that means you gotta know it. It'll definitely be an exam, and definitely you'll bump into it in the real world when we talk about drugs. Another thing that we also have to talk about is its mechanism of action, or MOA, and its side effects. Remember, we're playing around with the most complicated chemistry set in the world. So there's going to be problems. Maybe, you know, it's a running joke. Maybe you guys watched you know, when you watch a commercial for drugs, for any new drug, they always have these side effects like may cause nose bleeding, your left eye might not work, and you might die. I forgot what it was. It was I think it was for the new Lipitor. They said may cause death. So these are the things that a clinician has to look at. Would the benefits of the drug outweigh the potential issues of it? And just as a generality, if you take cardiac medications wrong, instead of doing good to your heart, it will do bad things to your heart. So there's a catch-22 situation when we mess with drugs. And I am my former profession was as a physician, as internal medicine, and I I I think very carefully before I start prescribing any medications. Which is also another thing we're going to be doing is showing you how to do prescription and medication orders. I'll be showing like samples of simulated doctor's notes where the handwriting is just atrocious. But nowadays there's electronic medical records, so the doctor chooses from a drop-down list. So that problem has been solved, but I cannot guarantee you will work for an old school or a mom and pop joint where the doctor still writes the prescription orders on a prescription pad. Now, dosage calculations. This is the biggie. This is the thing. It's like scheduled around week 7 or 8. This is the thing that future nurses, they had to actually supplement Pharmacology 2 and actually add more weeks of dosage calculations, because in our School of Nursing currently, it's one of the big boo-boos. Like if you're not good at math, please fix that. This class isn't the place to fix it, but if you're in your math 111, please focus on there, especially the section where they do fractions to fractions to decimals and so on and so forth. But I'll have because we'll probably do more than one session for dosage calculations. And immunization records, yeah, we're just going to touch on that. So these are the learning outcomes. These are the things we're going to be doing for this particular course. And the delivery mode, of course, is hybrid, meaning to say is we have online Zoom lectures at 9 a.m. Thursday mornings, and that's weeks 1 through 7. Week 8 will be on campus, but I will be doing it via this computer and then hooked up to a the screen. So if you're on campus, you'll be watching it live, and we'll be recording it live. And that's for week 8, 9, and 10. There will be a midterm examination, which will be take home on both weeks 5 and weeks 10. Okay. But if you want, on week 10, you could take it live and in person. So every week is worth, for all intents and purposes, is worth 10%. Okay. So that you should be working all throughout the program. Don't get behind, because that's a death nail for your grades. And now the campus is getting strict about grades. We just got a renewal on our accreditation, so the university is being really strict. In my 8 years of working for this university, in the first 4 or 5 years, no one got dismissed for grades. People just eventually dropped out on their own. Now we're starting to dismiss people. So please, if your grade point average is around 2 and under, you got to get it above that 2. And you got to also think about it. You guys are in medical. If you only know 73% of the material, you're going to hurt somebody and kill somebody when you're out there in the world. So always shoot for the higher thing, and also learn for learning's sake, because like I stated in new student orientation, with no disrespect to the other departments, but if you mess up a business plan, do you kill anybody? You mess up a cake or a meal, do you kill anybody? Well, potentially, if you're really, really bad at it. But culinary doesn't kill people. Business, nobody. IT, nobody. But healthcare, we have the potential to do much harm. And when you break everything down, the assessments, there'll be weekly quizzes, and your midterm and your final. And your midterm and final is worth about 10% each. And then your quizzes, 20%, discussions, lessons, and tasks. Now, what's lessons for us? Lessons for us is this. If you show up, right, you get attendance, even for a second, I goes, and we're recording right now. So I look here, I see 5 people, 1, 2, 3, 4, 5. That's attendance, and it's recorded, and it's irrefutable because it's on, you know, it's on video. So it goes, do your due diligence every week. I know as adults, it's really, really hard, but again, we're in a profession where you're surrounded by other adults as well. Don't even try, especially to ask any one of us, like, about kids, about life, or whatever. And if you think you have debt, ask any one of the doctors. My debt is probably 5, 6, 7 times greater than yours, right? So all of us have our crosses to bear, but as professionals, we got to do what we got to do. And it's outlined here, what we're doing every week, which mirrors Dr. Cisco's stuff here. And of course, week 10, final exam. And of course, don't forget your final survey. Take advantage, especially when doing discussions, take advantage of our library. Inclement weather policy. You can look up on the www.stratford.edu, look up rave alerts, RAVE. It's where the university can send you instant messages on your phone regarding closures. And the only class times we have to think about is March 4, March 11, and March 18. Or, you know, you can text me in the morning because if it's inclement weather for those days, I'll be up crazy early trying to figure out whether I should be heading out or not. Oh, campus security, that's self-explanatory. And again, that also expands to COVID. If you do not feel safe, please, I need to know now so I can get you an alternative assignment. And also, so you can have that alternative assignment so I don't mark you absent during the 3 days we're on campus. University-wide policies and procedures, I'm not gonna go over all of them, but all of them are located in your catalog. The ones I'm gonna go over right now as a reminder is the attendance policy. If you are absent 3 sessions in a row, you get automatically withdrawn from the course, and that will do a number on your financial aid. It'll also do a number on your academics. And if you're applying to our School of Nursing, that's not gonna bode well for you either. I have a student whose GPA is good, but she kept on withdrawing from classes due to attendance. Nursing didn't let her in. So just a little, another little public service announcement, because I got half a dozen students are in a world of hurt right now because didn't heed my warning in their beginning 100 level courses like this. And then now they're trying to get into where they need to get in, and now they're stuck, all intents and purposes. Honor code. If you want to cheat, and there's multiple ways of cheating, this is online, all well and good, cheat away. But if I catch you, you know, I have to bring it up to the academic committee. And if you get caught more than once, you could be dismissed. And again, the university just got their accreditation renewed, so they're being super, super strict. And last term, culinary dismissed 2 people for cheating. And the biggest thing is plagiarism. So if you're not too good at writing, and if you're not too good at, what do you call that, paraphrasing and doing your citations, your correct citations for your discussions, give me a call. Let's do a one-on-one Zoom. We can even do it today, and then, or after this class. Fix what you need to fix before you go out into the world, because I can tell you right now, honor code in the world is criminal, because we're messing with people's livelihood and people's life. And if you don't think that your office manager or the physician or your resident in charge in the ward won't prosecute you to the maximum extent of the law, oh, they will. It's actually standard operating procedure. So please, you know, don't cheat. It's not worth it. And if you're in the cheating game, you shouldn't be in this business. Okay. Alrighty, so that's my 2 cents. Well, not my 2 cents, the university's 2 cents as well. So, and all of this is in your syllabus. So we have the late policy here as well. Late policy for this class is everything, like all week 1 work, which is the discussion, and you have this quiz. It's due by next week. So today is the 7th, right? So your discussion, right, and your quiz is due, and it's an online quiz. It's due on before 9 a.m. on the 14th. For every day you don't put it in, that's minus 10%. And that goes the same thing for the lesson. For example, you missed this course or you missed this time, get a call to me because you have 6 days or so that to either get me another assignment or get some mini tutoring or something that I can justify giving you a lesson grade. So remember, your lesson grade requires your attendance for this particular time frame and or some scheduled tutoring. So if you're going to be out, please inform me in advance so I can get something to you, so I can not only post attendance but give you a grade for your lesson. Okay, so the study question quiz, I believe it's about 15, 20 items, multiple choice. That's due by next week, the 14th, before 9 a.m. And for every day it's late, it's minus 10%. So let's say you get 100 on the quiz, but you submitted it on Friday next week. Then it's what, 90? Or let's say you get an 80 and it's a 70. Oh, by the way, these study quizzes, the way Dr. Cisco set it up, and I'll keep it that way. It's unlike my quizzes in my other class, it's a one-shot deal. So take your time taking these pharmacology quizzes and go through these notes well, and the lecture before you hit the stuff up. Okay, and these are open books, so you can utilize Google, you can utilize any OpenStax or free material that's online. Okay, but just take your time. There should be no time limit on taking a quiz. All right, so what are we doing today? And of course, the discussion. Let's go over this. Medical professional recommend use of generic products, right? So why would you introduce generic? So in your introduction of your discussion, you have to now talk about generic versus the proprietary drug, and that's coming from today's lecture. So given what you learned about today's lecture, do you believe that generics are better or worse, or should the doctor or DNP be recommending this? And again, choose a side, yes or no, why, and make sure you have at least one citation, 7th edition APA format. And if you have trouble with this, either contact the librarian or myself, or you can go up here, you click on library, APA sources, and there's lovely instructions and videos on how to do this discussion. So without further ado, right, I'll open the floor to any questions, either on the chat or you can unmute yourself. Any questions about the syllabus? How's everything going to go down? And again, this lectures are recorded, so you can go back and check it again. If no one has any questions, anyone?
I do have one, Doctor.
Shoot.
So when you're looking at the discussion and it says products, I just like generalized, zone in on something. Is that just for drugs, or is that just
drugs,
general
drugs,
medical
pills, or any, and yeah, drugs in general. So let's focus it to pills, okay?
Mm-hmm.
Not the creams or anything else, just the pills. And
Okay.
like, is there a difference between, is there any real difference between a generic pill or a brand name pill? And we're going to talk about examples of that in the lecture. But that's it. Yeah, just focus on pills because there's a whole bunch of products in this world. But I believe Dr. Cisco, the original author of this, I think she meant just pills in general.
Okay, I just wanted to make sure I'm not going to write about all kinds of genetic medical stuff, generic stuff,
Yep. Okay.
All right, thank you.
All right, anyone else have any other questions? If not, if you think of something, put it in the chat or shoot me an email. Because many times, when you're in lecture, you're like, nah, I'm okay. But then you go home or you look at this video again, you're like, oh yeah, I should have asked them about this, that, or the other thing. Another thing to also utilize this thing up here. this chat box, I always check that. And if you see my chat box and my notification, you see how there's no red, because I always deal with it. And just like your announcements, just like your official Stratford email, you got to check it once when you wake up and one more time when you go to sleep. And that's a really good way to deal with things, because a lot can happen in 12 hours. Alrighty. That's the public service announcement portion of this class. So, and it's recorded, so it's all legal eagle. So let's start off with this lecture. You have no textbook, but Dr. Cisco created a whole bunch of scanned PowerPoints, and they were based on a former textbook we used to use. Now you may be wondering, like, oh, why don't we have a textbook? Well, when Dr. Cisco and Dr. Ostrander were developing this, they were like, why do we front the cost of all this stuff? Dr. Cisco has a doctorate. She write her own textbook, and she did in these PowerPoints. So I'm just going to briefly touch on this, the history of medicinal drugs, and where do we get the word pharmacopoeia. Now, pharmaco means medicinal preparations. And what is a medicine? And when you think about it, a medicine is anything that will mess with your anatomy or physiology to push you back towards homeostasis. And homeostasis means what? Normal, in the middle, right? So many of the drugs are made out of plants, minerals, and they could be placed topically, meaning on my skin, orally. I could inhale it. I can even be given rectally or vaginally. There's a whole bunch of ways, but for our discussion, let's just talk about pills, right? And that's oral, okay? So if I ask you what's a topical medication, it's a cream, something that I put on my skin, right? If it's inhaled, like an inhaler, because it's something that has to be breathed in, and we'll talk about the pros and cons of all of these things, okay? I always tell a little story that when I was a medical assistant, I had, well, the story changes. Sometimes I say I was resident, but I was a medical assistant. Okay, let me be 100% honest. I was a first year resident, which is not too good, this story. I had a patient, she had STD, so I prescribed to her a vaginal suppository. But I was in such a hurry in outpatient department that I just gave it to her, and I go, here, you take it, and you take it once a day in the morning, and you know, your rash and your itching and the STD should go away. But I need for you to come back in a week, and we'll see how it's going to go down. She comes back, right? And I was with the nurse, and she says, I still have the rash, it's still itching, and I don't know what's going on. It goes, I keep on taking the pills every morning. And then the nurse is looking at me like, how'd you take the pill? And she was like, oh, you know, like I swallow it with my orange juice. And she and I are looking at each other like, and who's stupid? Not the patient. I'm stupid because I didn't take the 2 seconds to tell her, oh, you got to put that in your vagina. And she says, it's funny because sometimes I mix it in with my orange juice and it froths up. And I was so embarrassed, and the nurse was giggling, and I felt so stupid. But then I put her on some oral meds, and you know, I just covered myself. But again, your patients aren't stupid. They are just misinformed or not informed, like in that case. So don't be the person to give vaginal medication per orum. That's the what do you call it? That's the moral of that story. So in drugs in the modern age, we started messing with chemistry, okay? So, and there's different classifications on what kind of chemicals do what. So one classification is therapeutics, right? That's when I want to fix something that's already broken, okay? So if I have a therapeutic drug like an antibiotic, that means you already have the infection and it is bacterial, so I give you an antibiotic to go deal with it. Or let's say you have a virus, I give you an antiviral drug because you already have it. But a prophylactic drug, if you recall your medical terminology, the prefix pro means before. So let's say, for example, you're going in for surgery tomorrow. 24 hours prior to the surgery, you get approved for your surgery. I have to give you prophylactic medication. I have to give you a broad spectrum antibiotic, broad spectrum meaning that it hits a whole bunch of different bacteria, because I know you're having surgery. And when you're having surgery, we're going to cut you open and then expose your insides to the 250 things that can kill you on the outside, right? So prophylactic medications we give before the patient gets sick, because we want to decrease and prevent potential disease, right? But again, you take antibiotics when you don't need to take antibiotics. It's supposed to kill pathologic bacteria. But guess what? If you take antibiotics the wrong way, the wrong time, you will get a bacterial infection. It's the irony of pharmacology. You know, if you have medications to prevent a seizure, but you take them wrong, guess what you're going to get? You're going to get a seizure. Pharmacognosy is an actual term, and this you'll see on your RMA and your CMA. Pharmacognosy is how the identification of natural sources for drugs, like where did it come from? Pharmacognosy is the knowledge, right? Like in diagnosis, the diagnosis of the source. Is it plant, animal? Is it mineral? And here's some classic examples. Ergotamine is fungus, right? And and ergotamine is an anti-seizure medication. Digoxin is a anti-heart arrhythmia medication, and that comes from the foxglove plant. Morphine, of course, happy, is from opium. It's from poppy, right? Some cave person probably looked at poppy seed and go, what's up? He goes, let me smell it. Next thing you know, high as a kite, right? So that's pharmacognosy, and here's some classic examples. Now, in modern pharmacology, we analyze some of these effects of these plants, animals, or minerals, and then we can make them in the lab. Sulfonamides, aspirin, also known as salicylate or salicylic acid, your sodium bicarb. These are drugs are produced synthetically. And sodium bicarbonate is a buffer, if you recall. And if you don't know what a buffer is, go back to your anatomy and physiology, right? So they get, another thing that we also do is now we bioengineer them. Epigen, which is a made from recombinant DNA technology. And what does that mean? We remember from our anatomy and physiology that DNA is the blueprint of who we are. We can take a virus, yes, a virus. We put it in there with our own DNA, with the DNA that we want, in the order that we want, and it can create a drug. And nowadays it's called designer medication. It's really, really interesting stuff. But the problem is it's now giving us DNA problems, which is scary, right? Because if I mess with your DNA, I'm not only messing with you, I'm messing with your future progeny, which is a little bit on the scary side. And I'm not familiar with Epigen, but Epigen is it's to help promote red blood cell hematopoiesis, red blood cell production for anemia. Here's some other samples. And here's omeprazole, very, very common, also known as Prilosec. So omeprazole is the generic name. Prilosec is the proprietary or brand name. And what does it do? Gastric acid inhibitor. So you take it for, like GERD or gastric esophageal reflux or hyperacidity in your stomach. So you can see here where knowing your anatomy and physiology and your what do you call that? Your medical terminology is really important. Pepsin, of course, deals with your digestion, right? Digoxin, we already mentioned, is cardiotonic, meaning the tone or how the force of your cardiac contraction. DIG is very dangerous. And if you have EKG with me tomorrow, we talk about digoxin poisoning and things of that matter. Silver nitrate, you may have heard of that, maybe if you had a bad burn, because if you burn your skin won't be good enough to fight off infection. So we put that silver nitrate on it, and it's anti-infection. And epigen, as I stated, is erythropoietin, stimulates red blood cell formation. So you could do this and make these little lists as you go along. And right now, on this lecture, there's so many lovely, lovely questions that we could do, right? So you won't be responsible for the chemical name, but in graduate school, by the way, you're responsible for the chemical name. If ever you guys want to get your DNP, and if you go into pharmacodynamics in medical school, you have to also know this. And oh, by the way, they make you draw it. But for my class, you only need to know is what's the generic name and what's the brand name. And here, and of course, what is its therapeutic effects, or what is its mechanism of action? What does it do for our patient? So for example, acetaminophen, which is the generic name, right? Also known as the non-proprietary name, but the proprietary name or the brand name or the trade name or the copyrighted name, and you guys know it as Tylenol, right? So for your discussion, is acetaminophen that you buy at the generic brand, is it just as good as Tylenol? And that's what you have to ask yourself, okay? And do your research and make sure it's in APA 7th edition format. So acetaminophen and Tylenol, we know it's an analgesic, right? An means no or not. Algia means pain. So got a little bit of a headache, I take acetaminophen, also known as Tylenol, right? And it should go away, or it should alleviate. And side effects, just right off the bat. By the way, if you're one of these people who take Tylenol to try to go to sleep every night, please don't do that. I'm from the Department of Internal Medicine. Try to get to the cause of what's causing you pain or what's giving you trouble. Like for example, if I have a gastric acid problem, yeah, sure, I can give my patient Prilosec all day, but I'd be asking, number one, what's going on? For example, my brother-in-law has severe GERD because he's a borderline alcoholic. Get rid of the alcohol, it gets rid of the GERD. And guess what? He hasn't had a drop of alcohol for 5 years. Guess what happened to his GERD? Went away. So I didn't have to put him on Prilosec and all these other gastric acid inhibitors, which by the way, mess with your serotonin, which by the way, could give you simulated major depressive disorder, which happened to my brother-in-law. And he's looking at me like, why are you giving me these drugs that make me cry in the middle of the day? And I'm like, which one do you want? You want crying, or you want your stomach to feel like it's burning, like it's on fire? He goes, okay, I'll have the crying. And then I told him, how's this? Lay off the booze. I used to have massive amounts of GERD when I was a smoker. I quit smoking. Guess what happened to my GERD? All gone. Alternative medicine. Herbs, supplements, homeopathic remedies. Now, the scary part of the alternative medicine is that many times the FDA, right here, the Food and Drug Administration, does not monitor this stuff. And a classic example was in the 80s that, what do you call that? There were some supplements that had similar effects to amphetamines. So I remember when I was in EMS, I thought my patient was, she was acting very disturbed, like she was on methamphetamine, like she was on drugs, but she was actually on diet pills. And the supplements were, were already kicking up her nervous personality. And when we did a toxicology screen, she was negative. But then we took the history, and she goes, yeah, I'm taking these herbal stuff that I bought at GNC to lose weight for some wedding or something. So drugs are regulated in this country by the FDA or the Food and Drug Administration. You don't need to know these acts, but just know the FDA deals with food and drugs. And the NDA is new drug applications. And new drug applications it takes years, 4, 5, 6, sometimes 10. And the reason it goes, and the reason why new drug application, right, takes so long is that we have to make sure that when drugs go to the market, that they're safe and that they won't hurt anybody. And here's the drug approval process. And let's see, here's the important part. This is on your CMA, AMT exams, your registry exams. They always ask this. There are 4 phases of clinical trials, and maybe you heard this in the news, right? Which have actually been expanded over the years. It's more than 100 people, way more than 100 people. But phase 1, what do you need to know about phase 1? We give the drug to healthy people to see if it will cause anything bad, right? Like something horrible. And if it doesn't, right? And they usually test thousands. Then it goes to phase 2. Then they start doing, start testing the drug on patients who definitely have the condition. So this is phase 2. They're looking for efficacy. Does the drug actually work? Phase 3 trials then have to compare it over a significant amount of time, like a year or two, to actual commonly used drugs. So let's say, for example, I have a new analgesic in the world. I have to compare it to Tylenol and to see if it's any better than Tylenol. And also, we have to also compare it against placebo, because we're going to be talking about placebos in a moment. And placebo is a fake drug, because the human mind is very, very interesting. If you believe that you're going to get well, and we already know this from anatomy and physiology. If you're going to believe you're going to get sick, you can upgrade your cortisol, right? And then you decrease your inflammatory response, and then you get sick. We know that from anatomy, physiology. That's why you get sick around tax time. That's why you get sick around midterms and finals, right? Because you're stressed out. But your body can do the same exact opposite. Your body can actually downgrade your pain. And I'm a gout. I have gout, and I don't, as an internist, I don't like taking meds. Sometimes when it gets really, really bad, I just try to relax and zone out, because I really, really want to reserve the drugs for when it's really, really bad. And you know what's funny? I still haven't used up even half my bottle of pain meds, and it's more than a year old, because I sit there and I try to focus out my pain. And I'm telling you right now, I'm a guy. I have like my threshold of pain is very, very low compared to you ladies. You ladies have babies and stuff. You guys can handle pain. Me, I'm splinter will bother me all day. And phase 4, we test that in the real world in post-marketing surveillance. That is when we let it out into the world, okay? And what I was mentioning earlier, did the current vaccines go through all of this? Yes, it did, but it went through all of this in a very, very short period of time, months. And that's why we're seeing now in phase 4 trials, very low efficacy rates. And what if the doctor told you, hey, take this drug, it might work half the time? That's not a good thing. And when we do these trials, we do a double-blind study. This is a very common question as well in your in your exams. A double-blind study is the participants in the study don't know if they're getting a placebo or the real drug, so they can rule out placebo effect. And in any study, you have 3 groups. You have one placebo group, one group that is one set of people that are healthy, and then they get a drug and a placebo, and then another group that that has the actual disease, and one set of that group gets the placebo, and the other set of that group gets the drug, or they take the 2 groups and switch them out. The overall concept of the double-blind study is you don't know if you're taking the drug or not. And if you don't know if you're taking the drug or not, then we can rule out the placebo effect. And nobody, now, the ethical problem with the double-blind study is that you are now withholding medication to a potentially sick person. And that's against the ethical rules of the Hippocratic Oath that that medical professionals take when you go out into the world. I'm supposed to do no harm, but in a double-blind study we have to, because we have to find out if the placebo effect is less than the actual drug, and we do that all throughout these 4 phases. So again, to recap: phase 1, healthy people; phase 2, people who have the condition; phase 3, we compare it to commonly used treatment; phase 4, we let it out in the real world and see what happens. Okay? Drugs definitely are not tested on pregnant women, because pregnancy is a different ball of wax, and also that's, why would I want to endanger an unborn child? It's a little bit on the crazy side. Pregnancy categories for drugs. This is also another big question. Category X is obvious. Do not use. That means it is teratogenic. Teratogen is, if you recall your medical terminology, is something that causes birth defects. Okay? And it's also the reason why we have, what do you call that? The FDA approval process, because of this drug called thalidomide. Back in the 60s, we didn't have this. So they looked at it, and it had like phase 1 and 2, and then they're like, okay, you know, I think it's a good drug. So, and it was a contraceptive drug called thalidomide in the 60s, and it got released in the United Kingdom. So they immediately chucked it out into the world, and guess what happened over the next couple of months? Babies started getting born with no arms and legs. They started calling them thalidomide babies, because when you started looking at the history, mommy took thalidomide even way before she got pregnant, and then it caused birth defects. So category A is good. Category B, there's some risk. C, for caution. D, there's a definite risk. X, do not use. Here's the thing. How's this? B, C, D, and X, no pregnancy. And also, if you're age 25 to 45 or of childbearing age, we will not prescribe that drug. So if I ask a question, if it's a category A, can I give it to my pregnant patient? Sure. B, no. C, caution. D, no. X, no. So B, some risk, right? But I'd try to find an alternative drug that has a category A, right? We talked about that. Removing drugs from the market. Safe doesn't mean harmless. Remember, oh, I didn't say this, but I'm saying this now. Anything is a drug, and anything can kill you. For example, remember homeostasis? How about water? If you don't have enough water, you're dehydrated, and you could die. If you have too much water, you'll be overhydrated. You're going to go into both respiratory and cardiac failure, right? So on either side of the spectrum, too much drug, too little drug, it could cause problems, okay? Blacksbox warning, right? You know, there's a whole bunch of warnings, right? And it's like, if there's any problems, it has to be published, and it has to be on the label. And actually, the FDA has all these rules regarding labels. So don't walk around with a, like, I had a patient, she mixed up her cardiac meds with her anti-seizure meds, because she started putting them in her own little boxes. And I had to tell her to stop doing that. You have to keep them in the thing that they're labeled, because your labels have also warnings. And also, when we talk about prescriptions, we're going to also show the different labels that could, that you could be exposed to. Ooh, here's another very big thing. Now, controlled substance. What's a controlled substance? A controlled substance is a drug that has a massive abuse potential. And the FDA doesn't deal with controlled substances, the DEA does, the Drug Enforcement Agency. and your DEA number is just as golden as your social security number. So if you're exposed to the physician's or the DNP's DEA number, guard that number with your life, okay? Do not let that out. And the DEA monitors physicians and other practitioners who prescribe medications daily. I am not exaggerating, daily. When I was a physician, I used to get calls like, if, let's say for example, typically I don't prescribe Percocet too much, but there was this one day where I prescribed it like 8 times. My attending got a call and said, "Hey, do you have a Dr. Garais on staff? This is the DEA. We're wondering what the hell's going on. Is he having a little sideline business?" And I had to fax them the legitimate reasons on why I had to do that. And now, nowadays your DEA number has to be renewed every 30 days, monthly, which is a pain. I no longer have my DEA number, but I still get the DEA alerts. And my mother used to be a physician. Well, she still is, but she's no longer practicing. She keeps up her DEA stuff because she just finds it easier to get drugs for her family that way. She's not doing any sideline business, but there are a lot of doctors. Just because you're a doctor doesn't mean you're a good guy or a good gal. You could be doing bad things, and the DEA needs to know about that. So now you know the DEA deals with controlled substance. And let's talk about the controlled substances. So the label will have a capital C with these Roman numerals, 1, 2, 3, 4, and 5. 1, highest potential, no accepted medical use. For example, well, I can't use that as an example anymore because there might be some medical use. Heroin. There's no medical need for heroin, right? So that is a class 1 drug. It has a massive abuse potential. Crack cocaine, right? All of that. Phencyclidine, PCP, all of that. Now, Percocet, which I mentioned, which is a very good analgesic, is very good for pain, is a class 2 drug. It is a high possibility to severe dependence. So if I keep on prescribing a whole bunch of class 2 drugs, DEA will start questioning it. 3, less, 4, even less, 5, lowest potential, but 3, 4, and 5 still is under the DEA and still has some level of abuse potential. Okay, and the way we measure abuse is the affinity to the drug to your body on how well the drug sticks to your brain, and that's called affinity, AFFINITY, or how sticky the drug is to a binding site. And we'll talk more about binding sites. Generic drugs. Maybe you saw the commercial for Cymbalta. Cymbalta is the brand name, and you know because it's capitalized. And the generic drug is in parentheses. Yet another drug that you need to know is Diloxatine, and it's an antidepressant, and it also is good for some pain, right? Did you think that could be on a quiz? Don't you think that could be an exam? Yep. Over-the-counter drugs. They do not require a prescription. But these drugs, the controlled substances, right? And something like an antidepressant, like Cymbalta, also known as Diloxatine. Oh, by the way, this course doesn't grade you on how to pronounce things, but you could Google them, and I would practice that as well, because it's sometimes I listen in on my wife's calls, and it's so sad when new medical professionals when they try to pronounce things, and it goes, "My patient's on an antidepressant, Duloxetine," and you're like, "Wow, really? Okay." Now, if you're not cited or not seen as a medical professional, how well are they going to deal with you? My wife's rolling her eyes and looking at her like, why am I dealing with this? And of course it wastes time, money, and energy. Primary objectives of the FDA. No, we're good. So that's that first lecture, and that's right here. So let's now jump to some basic concepts. let's, you guys know this picture. Yes. Let me, homeostasis. If not, oh, heaven help you. Heaven help you. Didn't retain anything. I had a professor who said, he used to call us Velcro heads. And I'm like, oh, that's not a nice thing to say. I didn't know what it really meant. And then he explained himself. He said, you should put Velcro on the back of your hand and then just put it on your forehead like you're forlorn or you're sad because you have no hope. He was so mean. So this is all that drugs do. Remember, we have a receptor that goes to our control center, our brain, and then our brain tells an effector to do something so we can have some balance. So when there's an imbalance, drugs also do what? Play around with our homeostasis. Drugs also push this little seesaw back and forth until we're what? Until we're balanced. So let's say, for example, my receptor is sensing pain. My control center is now interpreting that pain. And the effector would be what? Me making this face, sweating, I'm tired, I'm cranky. But then I'll do what? I take some meds, it change the imbalance, and then what will it do? It will change my whole entire homeostasis. Okay? So that's all that drugs do. Now, we kind of learned this from the from Anatomy Physiology 1 and 2, that receptors are just chemical proteins on top of the cell membrane. And then when a chemical messenger, right, and we know some of these messengers, histamine, prostaglandin, bradykinin, and we talked about them in Anatomy and Physiology 2, neurotransmitters, or the chemicals that are in our brain. So these chemicals go in there, and you see these chemicals have a particular shape. So let's say, for example, this chemical messenger is dopamine, right? Which is a neurotransmitter. And dopamine is linked directly to depression, right? Dopamine, also histamine as well, right? It's linked to depression. Let's say I don't have enough dopamine. If I don't have enough dopamine, the receptor won't kick in, and then I won't be happy. I'll be depressed. I'll want to kill myself. I don't want to eat. I don't want to get out of bed, right? That's no bueno, right? So what if I take a drug that looks like this triangle chemically? Then I could insert it in here. And then what will happen? The receptor will be tricked and go, oh, that's dopamine. And then what will happen? I'll get happy. I'll be back in the world again and then go back to work, right? Oh, by the way, you know what kicks up histamine and dopamine? Working out, right? Right now, I got gout pain, but you can hear me. You can hear my voice. I'm fine, right? I could sit there and be depressed about it, but guess what? I took my analgesic. It goes early this morning because my student called me crazy called me crazy early. So I did my run this morning, and it put me in a better mood, right? And it's gorgeous outside, so that also increase your dopamine. So that's what drugs do, and drugs match the receptors. So now when you watch these commercials with these little triangles, little shapes going into here, that's how things work, and how sticky or specificity, right? Now, if my chemical looked like a circle, do you think it'll fit here? Nope, so it won't work. So how's this? Do you think I could block things too? Let's say I have a chemical that makes me nuts, right? Makes me nervous, like adrenaline, epinephrine. Don't you think I could have another drug that blocks it so I won't be all nervous? It'll calm me down. It'll slow me down. So affinity is the strength or stickiness to a drug or a chemical messenger to its receptor. And specificity is the shape, the chemical shape that actually fits into the receptor. And they are protein molecules. And you remember what proteins are? They're amino acids connected by a peptide bond. Huh? Sound familiar? No? Yes? I would. I miss teaching in class because I used to love watching these blank stares that you guys give back at me. Maybe I should put the cam on so I can see like you looking at me like, huh? And it's just interesting because we just lectured about this stuff term or two ago. That's how interesting your memory is. So it's a good review. So again, specificity affinity, receptors, and what are drugs? Chemical messengers. That's all they are. And that's an MOA, mechanism of action. How does it work? Now, drugs could increase things, trigger things, right? Like I want to trigger my dopamine. So that's an agonist. Or I want to block my epinephrine. That's an antagonist. So blocking action, antagonist or anti, and triggering, agonist, right? And remember, if you have two things that look alike, what do? You memorize one, like your life depended on it, right? So you could have a blocker, antagonist, or you could have a trigger, right? Which is an agonist, okay? And you can see, depending on the shape of the drug. Okay, let's talk about these two. Well, this is the word pharmacokinetics here. And I'm trying, when I taught pharmacology, I put pharmacokinetics and pharmacodynamics in the same place. Let's do this. You have these two terms and they appear on your registry exam. So, and oh, I hate when it's on Pinterest. Okay, let me just magnify and move it over here. Okay. You have these two terms, pharmacokinetics and pharmacodynamics, because it's part of your pharmacognosy. Remember pharmacognosy we talked about a couple of minutes ago? Pharmacognosy is the knowledge of the source of your drug and what the drug does. So pharmacokinetics is what your body does to the drug. Pharmacodynamics is what the drug does to your body. Okay? Let me repeat that. Pharmacokinetics is what your drug does. Wait. Stop. Erase, rewind. Pharmacokinetics is what your body does to the drug. Pharmacodynamics is what the drug, the D, does to your body. That's how I remember it. Remember, if you have two things that are alike, I remember one like the life dependent on me. And for me, when I remember pharmacodynamics, D, what the drug does to my body, which is here. So what does pharmacokinetics means? Think about how when you swallow a drug, you have to absorb it. It has to distribute in your body, right? It has to be broken down, and I got to get rid of it eventually. I have to excrete it. So you could sit and try to memorize this, but just remember how pharmacokinetics, like how a drug goes into your body. I've got to absorb it somehow. I got to break it down. It gets distributed in my body, and then I have to eventually, either pee or poo it out, or, or it can come out of my skin or my sweat. So that's pharmacokinetics. Pharmacokinetics, let me choose my words carefully, what the body does to the drug. Now, what does pharmacodynamics do? D, what the drug does to the body. So the drug messes with receptors. It can change ion channels, right? It could mess with your enzymes, either block it or enhance it. And also it'll mess with your immune system. Here's the problem with a lot of medications, especially antibiotics and other things that will mess with the natural chemistry of your body. It'll drop your immune system. So if I have you on a lot of medications, especially with your geriatric patient, I'm already messing with your immune system. And that will lead to a whole bunch of bad. Okay? So pharmacokinetics versus pharmacodynamics. And pharmacokinetics with what your body does to the drug. One of the big things is called first pass effect. That's when your liver deals with anything that you eat orally, right? Oh, here it is. ADME, absorption, distribution, metabolism, or elimination. And absorption is easy. How does it go? How much of it goes in your body? Distribution. Where does it actually go? It could be bound to a protein, or it could be floating around. It goes, how does your body metabolize it? Meta means change, right? And of course, elimination, how do I get rid of it? Remember this, right? This looks like also the curve for enzymes, right? You got to get over the hump, and then you have an effect. Nice to know regarding dosing. But to get over the hump, just like, just like riding your bicycle, you have to have some energy. And that's why some drugs, you take a lot of it in the first couple of days, right? It's called a loading dose, and you go whoop, pushes you up the hill. And then after a while, there's a maximum ceiling effect. Then you have a maintenance dose. So the ceiling effect means that, let's say, for example, Tylenol. Maximum dose of Tylenol is 1,000 milligrams every 6 hours, maximum times 4 times a day. If you take more than that, more than like 8 pills a day, you're not improving, the analgesic or the pain relief properties. And that's why there's a maximum dose, and there's a, what do you call that? A ceiling effect or a maintenance dose, and you shouldn't go above it, because then you're going to increase the amount of side effects. Bioavailability, how much is floating around in your body. Bio, life, availability, how much is available. Now, remember we talked about efficacy? That's your therapeutic range. You see this blue line? Let's see if we can make this bigger. Can I make this bigger? Okay, cool. You see this blue line? In order for you to get there, that's your efficacious line. That's when things work. You see this red line? If I take too much of the drug and I keep on moving this way, right? Then I start having toxic effects. So that's your therapeutic range. And these drugs like DIG, lithium, lithium's bad. Lithium is like 0.1 gram either way. Give you seizure, put you in a coma. But lithium is used for bipolar patients to even them out. But all these drugs here, right, have a narrow therapeutic range. So if I ask on a quiz, what does therapeutic range mean? It means the amount of drug, the safety of the drug between its therapeutic range and its toxic range. So your therapeutic dose versus a toxic dose, right? So the safer the drug, the wider the range, like Tylenol. You could take 2 bottles of Tylenol, you won't die, you'll just get really, really sick. But hey, you take an extra pill or 2 of any of these drugs right here, call it a day, you're not going anywhere, right? Duration of action makes sense. There's some drugs that are long, some drugs that are short. Drug effects, indications, contraindications. Sometimes drugs only work locally, like a cream. If I put a cream and I put it on topically, it's only going to work in that area. But if I take a drug that I have to eat and that has first pass effects, meaning it goes through my liver, it's going to affect my entire body. So, when you take drugs, that's some things to take into consideration. Indications, what do I use the drug for? Contraindications, what I can't use the drug for, right? So when you go to medical school or for more advanced degrees and training, you're going to have to learn indications and contraindications of every single drug. But nowadays with electronic medical records, it's really neat. When I put in the drugs that I want to give to my patient, the flag comes up and tells me, hey, do you know that this is contraindicated in your patient? Blah, 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 right? Side effects, drug interactions, right? And we mentioned the drug interactions earlier. Agonism or antagonism, it can make it worse, or it can make it better, or it can increase it, or it can block it. Now, there are some drugs that we use in combination, like cotrimazole, which is a sulfa drug, and I forgot now. I forgot now, and I'm the one teaching the class. Well, there are some drugs that are in combo. They either potentiate one another or they cause synergy. That means one drug will make the other drug more powerful, okay? Either way, we're gonna increase the effects of the drug. So this looks like a beautiful both A and B question, doesn't it? All righty, it's now 10:09, and we went through pretty quick. This main these main topics that we have for today, which is more than enough. Now, here's some supplemental information. These are nice to know, and we kind of talked about its generalities in here, but that's how every week's going to go. As you can see, Dr. Cisco put these lovely, lovely lecture notes. And this will be your main topics. And it's this point of the show, I'm going to stop the recording.